Swayam Prabha. Digital India. Educated India.
Welcome to this session. In this lecture, we will be learning about urothelial tumours. So, urothelial tumours, its etiology, the genetics, the pathogenesis, morphology, the classification, recent advances in molecular classification which has become prominent since 2020, then the presenting features as well as progression and its prognosis. 90 to 95% of bladder tumours are found to be epithelial in origin, and amongst these the most important and most common one, accounting for about 90% of these epithelial tumours, is urothelial neoplasm. Now, urothelial neoplasm is found to affect globally because of industrialization, and it is thought to be amongst 9th global carcinomas, and in the US it is 4th most common in men, as well as 7% of new cases are found to be those of urothelial tumours. It is thought to be non-familial most often, and a male is to female ratio of 3:1, accounting for malignancies mostly seen in the 50 to 80 year age group, and this is thought to be because of the associated factors responsible for these tumours. It is seen most often in higher income countries, especially in the urban dwellings or in the urban areas, and this is how it looks. That is, you have two types of precursor lesions in these, the papillary lesions and the flat lesions. So, the papillary lesions will give rise to invasive papillary carcinoma, and the flat lesion will give rise to flat invasive carcinomas. Okay, location wise, it is noted to affect any area in the urinary tract where the urothelium is there, which means from renal pelvis till the distal urethra, anywhere it can affect, and because these carcinogens can affect any part of this system, it can be multifocal. It may be benign or it can lead to aggressive tumours also. The precursor lesions, as I told you earlier, are two types, that is papillary tumours, the non-invasive ones, as well as flat non-invasive carcinoma in situ. Epidemiologically, tobacco use is thought to be the most important part, and it is accountable for 50 to 80% of the cases, and cigarette smoking in that is very important. About 3 to 7-fold increased risk of malignancy is seen with the smoking of cigarettes. Less commonly it is because of other tobacco use, for example as cigars or pipe smoking or even smokeless tobacco. Next common is industrial exposure. Malignancies are thought to arise even 15 to 40 years post exposure, specifically to arylamines, in that to naphthylamines. Schistosoma hematobium also causes bladder tumors, specifically squamous cell carcinoma. About 70% of the tumors are squamous cell carcinoma, and this is because the ova will deposit in the bladder wall, and then it causes irritation and subsequently metaplasia, which is squamous in nature, and then this squamous metaplasia after accumulation of various mutations, it becomes malignant. The remaining 30% of them is thought to be either urothelial carcinoma or rarely an adenocarcinoma. Long term use of medication is another important factor, in that analgesics. Then cyclophosphamide, besides causing hemorrhagic cystitis, it can lead to malignancies. Radiation exposure for various malignancies, especially pelvic radiation, can after a prolonged period give rise to urothelial carcinomas. So, what happens in these urothelial carcinoma? What exactly is the background for non-neoplastic epithelium to progress to neoplasia? So, two important pathways are there. Now, one of them involves mutations in the RAS and FGFR3. So, what happens there? These are gain of function alterations in FGFR3, which give rise to the altered signal and increased intensity of signals within the cell, and therefore, since it is growth factor receptor which is responsible, therefore, it causes growth of the cell. Now, along with that there are RAS and PI3 kinase pathway are affected. Now, in these genes it is activating mutations. Till here it will be non-invasive. Subsequently, further mutations occur, especially involving P53 and RB, and then it becomes invasive. So, how many of these will become invasive? Just remember that 80% of these remain non-invasive even in the recurrences, but 20% of them can be invasive. Now, by invasion I mean muscle invasion and not just lamina propria invasion. Recurrences, however, are very frequent along this pathway. The next pathway is TP53 and RB mutations alone. So, these give rise to flat carcinoma in situ, and subsequently other mutations it gives rise to invasive carcinoma. Remember that in the first pathway TP53 and RB mutations are later on. So, initially in the non-invasive phase it does not, but whereas when it becomes muscle invasive it gets these mutations, whereas in flat lesions the TP53 and RB mutations occur earlier on itself. So, this is about the pathogenesis. Now, I was specifically talking about molecular classification also. So, they have done extensive genomic studies in this and tried to map out all the mutations involved, and they have noticed that there is a high burden of somatic mutations, around 58 have been identified, and these involve the oncogenes, tumor suppressor genes, including those responsible for cell cycle regulation, chromatin regulation, DNA repair, as well as growth factor signaling pathway. So much so that when they did RNA expression analysis, they identified distinct molecular subtypes. Okay, based on that we have the latest consensus molecular classification of muscle invasive bladder cancer, and in this there are distinct subtypes. Now, based on these we have specific classes, that is 4 classes are there, which include urothelial luminal, stroma rich, basal and squamous, and as well as neuroendocrine. Now, under urothelial luminal we have a few more subtypes. These will be luminal papillary or lump, then luminal non-specified lump NS, then lastly luminal unstable. Now, the importance of these is that they have specific morphologies also. The luminal papillary and luminal non-specified present a papillary morphology, with luminal non-specified even showing micropapillary variant. So, how are these tumors classified? The tumors of the urinary bladder are classified as urothelial tumors, adenocarcinoma, squamous cell carcinoma, mixed carcinoma, small cell carcinoma and sarcomas. We will be looking at urothelial tumors, which can be non-invasive or invasive. Now, amongst non-invasive there are different types, that is urothelial carcinoma in situ, then papillary urothelial carcinoma low grade and high grade, then pun lump or papillary urothelial neoplasm of low malignant potential. Then there is the papilloma, which can be classical or can be inverted. Then we have urothelial proliferation of uncertain malignant potential and urothelial dysplasia. Amongst the invasive urothelial carcinomas, we have nested, microcystic, micropapillary, giant cell, sarcomatoid, poorly differentiated, lymphoepithelioma like, lipid rich, clear cell, plasmacytoid and signet ring. So, these are different variants besides the classical urothelial carcinoma that we can see. So, urothelial tumors can be grossly small and which are usually benign, to large aggressive tumors, and most often it is thought to be multifocal because of the stagnation of urine there, causing the carcinogens to be exposed to different areas of the urinary bladder. Now, as I said earlier multiple times, there are 2 distinct precursor lesions. You have the non-invasive papillary tumor, then you have the carcinoma in situ, which is flat. Then prognosis worsens with muscularis propria invasion, so much so that the 5-year mortality for these cases with muscle invasion, also known as muscle invasive bladder cancer, is almost 30%. So, now these urothelial tumors, for simplification, can be divided into flat lesions and your exophytic papillary lesion. So, first the flat lesions, the same classification as I told earlier, but it has been divided now into 2, that is flat lesion and exophytic papillary lesion. The flat lesion include your hyperplasia and then urothelial dysplasia and urothelial carcinoma in situ. and the exophytic lesions include urothelial papillomas, then urothelial proliferation of uncertain malignant potential also known as papillary hyperplasia, then the pun lump or papillary urothelial neoplasm of low malignant potential, papillary urothelial carcinoma low grade and high grade. Now, these are all non-invasive ones. When it becomes invasive, we call it as muscle invasive bladder cancer. So, grossly these depend on whether it is a papillary exophytic lesion or it is a flat lesion. If it is a flat lesion, there will be just mild elevation of the mucosa or sometimes just change in color, there may be reddened, and papillary lesions either are papillary with multiple excrescences or nodular. Now, these could be 1 to 5 centimeters in size and they are usually red and elevated. Now, both these tumors can be invasive or non-invasive. The most common site of involvement are the base, in that this is the lateral and the posterior walls at the base. Now, first we will look at papillomas. These are exophytic, these are very small. Remember that they are very small and affect the younger patients more often. This account for just 1% of all bladder tumors. They rarely recur or progress. Grossly they are single, exophytic, very small, up to 2 centimeters. Anything more than that, you should immediately suspect some other tumor and not the benign papilloma. Its delicate papillary structure with a stalk. So, how do we distinguish this from a small sized pun lump is there will be a stalk in this. So, microscopically it has certain features, that is finger like projections with the central loose fibrovascular core as seen in this picture, and then it is lined by multiple layers of urothelium which is normal urothelium. There is nothing abnormal in this, nothing, no anisonucleosis, no karyomegaly, no mitotic figure increase, nothing. So, absolutely normal urothelium, but only thing is that there is a papillary structure. Now, besides this classical papilloma, I already told you in the classification we have an inverted papilloma. So, inverted papilloma also will be a small lesion, and in that we see we do not see any gross structure as such, just mild elevation. We will not see any papillary excrescences. Instead, it is a microscopic diagnosis. Under microscopy, you will notice cords and nests of urothelial cells which are bland, which are going into the stroma. So, the problem here is that microscopically, though it is bland, sometimes it can give rise to misdiagnosis of invasive malignancy, and that is where we have to be extremely careful. Importantly, remember that the inverted papilloma will also be very small in size. Now, the next tumor is a papillary urothelial neoplasm of low malignant potential, which we say pun lump. Now, cystoscopically these resemble papillomas, but they are more than 2 centimeters in size, and it can grow quite large also and can be similar to invasive carcinomas grossly, and they may recur, but when they recur they have the same histology. Remember, these do not invade. So, this is your pun lump, and here you are seeing microscopically similarity to papilloma, with the difference that the urothelium is much thicker, that is more layers of cells are there, and mitotic figures are there which are usually basal as seen here. If mitosis in these you have to count and detect the location, because a little more than that will be seen in the next condition, which is papillary urothelial carcinoma low grade. In this gross differences are not there, it will be similar to papillomas or even to your high grade papillary urothelial carcinoma. Now, microscopically most important aspect is that the architecture is maintained. Numerous papillae are there which are discrete and not confluent. This is a very important aspect of low grade papillary urothelial carcinoma. So, it is a maintained architecture and they are orderly placed. They can recur and rarely they can invade. Microscopically you get preserved polarity and cohesive cells with very mild nuclear atypy and hyperchromasia. If there is mitosis, then it is suprabasal, and that is how we detect this and differentiate it from your papillary urothelial neoplasm of low malignant potential or pun lump. Next one is a high grade papillary urothelial carcinoma. Microscopy is important here because gross is, as I said earlier, it may be similar to low grade papillary urothelial carcinoma. So, there is severe architectural disarray, there are confluence of papillae and sometimes fused papillae will be there, too many, with the loss of polarity. As you see here, you see hyperchromasia, marked anisonucleosis of pleomorphism, numerous mitotic figures will also be seen. There are discohesive cells which will be shed in the urine, as well as necrosis may be there. High incidence of muscle invasion, progression and metastasis in these tumors. So, muscle invasion, more than 80% of these high grade papillary urothelial carcinomas can invade the muscle. Next is carcinoma in situ or carcinoma in situ, usually seen as flat lesion. Okay, carcinoma in situ, cystoscopically it is different from the usual papillary tumors. Here the mucosa is reddened, thickened or granular, or it could be all of these. Now, there are no intraluminal mass, and once you see this area in the cystoscopy, you have to look for other similar areas because most often it is multifocal. So, sometimes the entire mucosa of the urinary bladder can be involved, or it could be patchy and it can involve even the ureters as well as urethra. If left untreated, about 50 to 75% of them will progress to invasive carcinomas. So, this is the normal urothelium progressing to carcinoma in situ, full thickness invasion, and as you can make out here in this picture, the basement membrane is intact. To say carcinoma in situ or in situ, it is very important to look at the basement membrane to see if it is intact. So, here it is involvement of the full thickness of the urothelium. So, microscopically flat urothelial carcinoma, as I said, you get cytologically atypical cells, so much of atypia that it looks malignant, but it involves only the full thickness of the urothelium with an intact basement membrane. Sometimes these are very discohesive and you can be seeing it as a single lining because most of the cells, because of the discohesiveness, may be shed in urine. At times these malignant cells will invade the adjacent normal urothelium and look like a pagetoid spread. Clinically, these patients usually present with the painless hematuria. This is very important cause of painless hematuria. Now, besides painless hematuria, other symptomatologies include hematuria with increased frequency, then dysuria, especially in case of flat CIS, then urgency, and then depending on whether there is an obstructive lesion which is causing this. So, obstructive symptoms will be when tumors, urothelial tumors involve the urethral orifice. So, in that case you will get pyelonephritis as well as hydronephrosis. Now, the clinical features also depend on whether it is muscle invasive or non-muscle invasive. So, we will have a look at the non-muscle invasive bladder cancer first. So, non-muscle invasive bladder carcinomas have a tendency for recurrence. Progression, only few of them progress, but when they progress it is usually higher grade or stage. Now, both recurrence and progression depends on the initial tumor, what stage it is, what grade it was, and presence of adjacent carcinoma in situ, as well as if these lesions are multifocal. Recurrence occurs in 70% of the cases, and when it recurs it may be a higher grade and maybe a different site. Now, if it is in a different site, it could be either implantation from the primary tumor, in which case it is clonally related, or it could be another primary tumor in which case it is clonally distinct. Now, the treatment wise in non-muscle invasive bladder carcinoma, there are two options, either transurethral resection of the bladder tumor or intravesicular your Bacillus calmette urine, which is attenuated Mycobacterium bovis strain is used here, and intravesically it is injected. Now, TURBT is done in papillary urothelial carcinomas which are small, localized and low grade, whereas intravesical BCG is done in flat CIS most often, but also in papillary urothelial carcinomas if they are large, high grade, multifocal or showing lamina propria invasion in the biopsy. So, how do they progress? Now, in less than 10% of them, they can become higher grade, and prognosis depends on invasion, that is on the stage which we will be having a look at later. But these patients with non-muscle invasive bladder carcinomas, they have to have lifelong surveillance to detect progression as well as to detect the higher grade arising in subsequent tumors. So, for that they have to have lifelong cystoscopic examinations, then biopsies as well as urine cytology to detect recurrence or progression. The survival rate in these cases is 98%, that is a 10-year survival rate in cases of papilloma, spun lump as well as low grade papillary urothelial carcinoma, whereas it decreases to 75% in case of high grade papillary urothelial carcinomas. In case of carcinoma in situ, however, it depends on the association of invasive or non-invasive malignancy adjacent to it. So, carcinoma in situ without invasion, 93% of them survive over 10 years, whereas it reduces to 55% in case of association of carcinoma in situ with muscle invasive bladder carcinoma. So, with this we move on to the next type of bladder carcinoma, that is your invasive, muscle invasive bladder carcinoma. So, muscle invasive bladder cancer is mostly associated with papillary urothelial carcinoma high grade. So much so that whenever we see papillary urothelial carcinoma high grade, we always inform the clinician that this is a high grade tumor. So, further biopsies may be required to check for muscle invasion. Okay. Carcinoma in situ progression to muscle invasive bladder cancer depends on whether it is pure, in which case only 28% of them will progress, whereas 59% of them if associated with adjacent muscle invasive carcinoma. Now, locally these tumors will invade to the prostate, the adjacent seminal vesicle, ureters, retroperitoneum, etc. Metastasis could be either lymphatic or blood-borne. Lymphatic, it is initially regional lymph nodes, then in blood-borne it is usually to the liver, lungs and bone marrow. Now, prognostic factors depends on the PTNM staging as per AJCC staging protocols, in which we check for the depth of invasion as well as extent of spread. Therapy of these patients is usually radical cystectomy or cystoprostatectomy, or sometimes radiotherapy with neoadjuvant chemotherapy or adjuvant chemotherapy. Okay. Of late, immune checkpoint inhibitors have also been tried in this, and it is still on a trial basis. Now, besides muscle invasive bladder carcinoma, radical cystectomy can also be used for other indications, and these include non-muscle invasive bladder carcinomas if they are multifocal, large or extensive, carcinoma in situ in prostatic urethra and ducts, or carcinoma in situ or papillary carcinoma which is refractory to intravesical BCG admission. So, finally, we move on to the pathological staging of urinary bladder carcinomas. So, this is the PTNM staging according to the AJCC 8th edition. Finally, to summarize, 90% of bladder tumors are epithelial, 90 to 95% actually are epithelial neoplasms. Of these, 90 to 95% are urothelial tumors, and they can arise anywhere from renal pelvis to distal urethra. Most often they are multifocal and they can be benign and aggressive too. Usually occur in older individuals in the 50 to 80 year age group, most often in males. Tobacco is the dominant etiological factor. The precursor lesions include papillary lesion as well as flat carcinoma in situ. Papillary tumors have different types and grades. The molecular classification has been attempted in these, especially in muscle invasive bladder carcinomas, which have been divided into urothelial luminal, stroma rich, basal and neuroendocrine types. Then based on muscle invasion, again it has been divided into two, that is non-muscle invasive bladder cancer, bladder carcinomas and muscle invasive bladder carcinomas, mainly because they differ both in the prognosis, the progression as well as in therapy. So, muscle invasive bladder carcinomas are usually associated with P53 and RB mutation in the initial aspect itself. The precursor lesion is flat or a high grade papillary urothelial non-invasive carcinoma, and these are treated by cystectomy or cystoprostatectomy or by radiation therapy with chemotherapy, either neoadjuvant or adjuvant. The non-muscle invasive bladder carcinomas are papillary tumors, and related to FGFR3 alterations, then RAS and PIK3 kinase mutations, P53 and RB mutations occur late in these tumors, giving rise to the invasion, and these are known for recurrences, and progression is very rare in these tumors. So, with that we conclude this session. Thank you for an attentive hearing, and good day to all of you.